Glad to have you here. My name is Lynda Rowe. I'm Senior Advisor of Value-Based Markets at InterSystems. Many of you have probably intersected with me or have heard my voice. So I'm going to talk about how HealthShare, and we'll go a little broader than that, supports things that have come out of ONC and CMS sort of over the past year and a half, 2 years. I was hoping that I'd actually have some new stuff to talk about today, but we're all holding our breath, waiting for CMS to sort of drop a rule. Here, that'll happen soon. But I'm going to take you on sort of a whirlwind journey. And for folks who don't know me, I am a policy junkie, so I'm actually one of those people that picks up these documents and likes to read them. Not everybody does, though. So what I spend a lot of time is I read these documents and try to figure out when rules come out, when regulations come out. First and foremost, what does it mean to the industry? What does it mean for us as a company? How should we be thinking about it? But I think of it through the lens of what does it mean for you, our customers, and our prospects, and how should we be thinking about implementing it, yes or no even, in our technology. So I'm going to talk about some important regs that have happened over the last couple years, impacts on you folks, some of the solutions we've built out. Hopefully you'll walk away understanding things that maybe you don't understand, because if you're in the payer market, maybe you haven't heard about some of the fun things happening in the provider market and vice versa. We talk about organizational impact and some of the stuff that we've built into the product over the past couple of years to support. So I'm going to, like I said, this is a really, high level, fast, let's go through what's happened. So I'm going to talk about TEFCA. That's an ONC rule. So Trusted Exchange Framework Common Agreement. I'm going to talk about sort of the No Surprises Act, which is something that came out that impacts both payers and providers. That was actually an omnibus law that then has, in pieces, been rolled out through rulemaking through CMS. They actually haven't gotten to the provider directory provisions. They've gotten into some of the thornier things in their rulemaking. And then I'm going to talk about the CMS interop rules, talk about for providers, and then I'm going to go through some of the payer stuff. I'm going to talk about price transparency, and time permitting, I can talk about Cures Act and information blocking. So, a lot to cover. So, this is something ONC has been working on for a while, because it actually came out as part of the, not the high tech, sorry, the, thank you, Affordable Care Act. And basically, TEFCA, Trusted Exchange Framework and Common Agreement, is a set of requirements to govern a national network for exchanging documents. So think of it as the interoperability highway, which is the way that we often hear them talk about. Sort of, we all have parts of that. There are pieces of exchange happening, but they're not all interconnected. And so this is the way to try to connect all the pieces together and create sort of an interstate system, right, that then has on-ramps. So the Trusted Exchange Framework is the principles that are designed to facilitate trust between what they call a HIN, or Health Information Network. And then the principles, are standardization, transparency, cooperation, non-discrimination, privacy, security, patient safety, access, and data-driven accountability. So those are sort of the rules of the road. If I want to participate, I have got to agree to basically be a good citizen. And then the common agreement has all the technical components. So if you are going to participate and be what is called a QHIN, and I'll talk about QHINs, it is that technical framework that says what are those things that I have to do and support, both from a legal agreement perspective, but also what kind of infrastructure do I have to support. And basically, right now, what's written into the law, or the way that ONC is rolling it out, because it's not written into the law, is that it is a query-based exchange. However, there is a roadmap to transition QHIN to QHIN exchange to be FHIR-based. So how is this going to work? So first and foremost, ONC designated what they called the RCE, the coordinating, regional coordinating entity, right? And they're basically taking the rules and the regs and turning that into a set of policies. And they've been doing this over the past couple of years. And they finally came out with their final draft of our final version of this at the beginning of the year. So they then have oversight and governance for what's called the qualified HINs, Health Information Networks, or QHINs. And if you look in this diagram, sort of they're the governance umbrella, and then you've got QHINs. And it was interesting because certainly, I think many of us, when we first read about TEFCA and the QHINs, thought, oh, a lot of the big regional HIEs will probably throw their hat in the ring and become QHINs and connect, use their local connections and connect to one another. But what we have subsequently heard is that it's actually, they're looking for those that already have a national presence. And if anybody has read the news this week, Epic just announced that it's going to apply to be a QHIN. And I know that a number of HIE customers thought they might become a QHIN, but if don't have that national reach. Folks like Commonwealth will probably apply eHealth Exchange. So think about the big national networks, and they're the ones that will likely be the QHINs. And there are a whole bunch of rules of the road in terms of the fact that, again, they're going to be doing IHE profile exchange from QHIN to QHIN. They can't charge each other a fee or money for talking to one another. They can, however, charge a fair amount to their participants. So if I am a large IDN, or I am an HIE, or I'm a payer that wants to connect to a QHIN, the QHIN can charge a fee, a nominal fee. That'll be interesting to figure that one out, right? What's nominal? To connect. And so the theory is that if I am a participant, I can query through my QHIN and ask for information. So please send me all the information you have on Lynda Rowe, and it can be two kinds of exchange. It can be directed, meaning I just want Lynda Rowe's information from this health system down in Florida. Please bring that back to me. Or please go look across the national network and see what you can find on Lynda Rowe and bring that back to me. So, as I said, ONC is defining the overall policy and requirements. The Regional Coordinating Center entity is doing the oversight. The QHINs connect to each other, and then each QHIN connects to participants, which connects to sub-participants. So that's sort of the architecture of how this will all work. What I think is interesting is these permitted purposes. So ONC outlined a set of initial permitted purposes. There actually were more than this, but for the initial use cases, so querying for public health purposes, for treatment, payment, operations, so TPO, individual access, and I think initially, benefits determination are more for Social Security Administration, so looking for benefits information for somebody covered for disability under Social Security. Now, the requirement to return a response is only required in two use cases. So I can query as a payer, and I have a TPO reason to ask for data back. I don't have to get a response because it's not a required. There are only two. Guesses? Which two? Treatment. Patient access. So an individual has the right. So if I've got a third-party app and I query because I'm connected to a local IDN, or I connect directly to a QHIN because that app happens to do that, a response has to come back to me. Those are the only two use cases, so that'll be pretty interesting. Currently, there is also no requirement to be a QHIN, to connect to a QHIN, so this is all sort of goodwill thing. So again, that'll be interesting to see sort of who's in and who's going to stand on the sidelines and wait to see what happens. No surprises. So the No Surprises Act was a big piece of legislation that came out in 2020. And basically the way I like to talk about this is your rights to not get surprised. How many of you have ever gotten a bill from a provider that's like so big and you're looking at it and going, how could this ever happen? Yeah. And it happens for a few reasons. You know, one is that unbeknownst to you, your health system might be in network for your particular plan. But guess what? The anesthesiologist isn't. So you get this giant bill because you had day surgery and the anesthesiologist was out of network. Or the radiologist who read the report of the x-ray they took of you before you had that surgery was out of network. So what this is doing is saying that we're not going to make this your problem anymore, patient. You only should be paying what would be normal if they were in network. So that doesn't mean you're off the hook. It means if you've got a $25 copay or you've got a co-insurance, you still have to pay that. But it's not this like, wow, I have a $800 anesthesiologist bill that I wasn't expecting. And they're basically saying this is going to be a problem that needs to be adjudicated between your provider and your payer, and that they've kind of got to figure out that in their whole set of rules that have dropped in CMS that talk about it. I don't have time to go through those. But the piece that we're particularly interested in at InterSystems was sort of the provider directory requirements, because we do have a provider directory product. And so if you think about those requirements on the provider side, providers and facilities must have in place a process to update and share provider information with payers when a certain significant event occurs. So, and there's a set of events that says under these conditions, provider has to give updated data to their payer partners. On the payer side, on provider data, providers have to have a verification process. So they have to have a way to verify that the information in the directory is accurate. They have to have a response protocol, which means if a member asks for that information, either over the phone or online, they have to respond with information about whether that provider is in and out of network within a time period. And then they have to have sort of an up-to-date database, and there again, there are some rules about how often that has to be refreshed and what other types of information they can get and how often they can get it from the provider network. So I was talking about sort of so payer and provider, you now have to figure this out. And so there's a 30-day period for negotiating between the providers and the health plans on what that who pays what part of the bill that's not covered. But there's a backstop of what's called an independent dispute resolution process to resolve those payment disagreements. And clearly, it is in nobody's interest to go to a dispute resolution process, but it exists. Second, for uninsured individuals, there is also a dispute resolution process. So if a patient's billed substantially in excess of a provider's good faith estimate, then that can be disputed. And then this is the part sort of we are focusing on is the transparency sections requiring provider directories, as well as, and this is interesting because this is something we're actually looking into now in terms of how we could use Iris for Health to do this, but furnishing advanced cost estimates, an estimated out-of-pocket cost for specific services, and they've listed the services. And the health plan maintaining of a provider price comparison tool. So this is an interesting thing. So recently, I did something to my shoulder and had Fortunately, cortisone shots are amazing things, so that resolved the problem. But had I needed to have shoulder surgery, technically under this rule, which went into effect this year, my provider would have had the obligation to provide me a good faith estimate of what that would have cost me in their facility. I don't know how often this is happening and whether it's really happening or not, but it is part of the rule. I think the other interesting thing about this rule is that if you, as a patient or member, go to either your provider's website to look whether a provider is in network, or you go to your payer's website to see if a provider is in network, if you make a care decision based on that data that says they were in network, and subsequently you find out they were out of network, it is not your problem. Again, it gets punted back, and the payer and the provider have got to figure that out. So this rule is really trying very hard to make it more transparent, right, about what you should or shouldn't have to pay for. And like I said, we have been talking about sort of good, clean data in our provider directory, and we're also looking into how we can support some of the provisions around the good faith estimate using Iris for Health and ingesting some of that data. All right, so CMS, switching channels. So I'm going to talk about CMS rules for payers. So refresher, in January of 2021 with the July enforcement, there were two provisions. One was patient access APIs, and the second was to expose provider directory using FHIR APIs. That actually went into effect last July. And then the second one was peer-to-peer exchange. That was supposed to go into effect of January this year, but that one is actually, there's no enforcement discretion. In other words, they are not going to enforce it, and I will explain to you why. So again, what did we do? When the rule came out, the first thing we did is we read the rule and figured out, and we actually came out with a solution pack, a way to support this, and a number of our payer customers actually used our technology to support patient access APIs, provider directory APIs, and are awaiting peer-to-peer exchange. We ingest the data. We have FHIR APIs to support patient access APIs, as well as the security provisions. We ingest the existing provider directory data, expose that through FHIR. And then I want to talk a little bit about what we're doing around peer-to-peer exchange. So here's the deal on peer-to-peer exchange. When it came out in the CMS regs, first and foremost, there was no implementation guide at all. Second, the rule only said, here is the data standard. Here are the data elements you need to exchange from one payer to another. And the use case for this, by the way, is if I am a member and I am transitioning from one plan to another, it would be really nice if the new plan knew things like, I have already gone through a step process to be on a certain type of drug, so that when I get to the new plan, I don't have to start all over again with my provider to provide that documentation. Or say I was in a disease management program with my old payer. It would be nice for the new payer to have that clinical information and to know that, so they can pick up where sort of you left off in that path. So that is sort of the use case behind this. The problem was there was no transport standard. So what does that mean? That means that I pretty much could send that data from old payer to new payer in any electronic format I wanted. That was going to create havoc on the industry. And a lot of payers actually pushed back, and we, InterSystems, participate in the HL7 Da Vinci project, and we have a lot of the very large national payers that sit in on that, as well as some regionals, and they all said, this is not something we want to support, because it means we are going to continue to have to ingest data in all these different formats. There's no standard. and it's just going to get bigger and bigger and bigger, this problem. And CMS actually listened and said, you know what? We're going to give you enforcement discretion, which means we're not going to audit you or check you on. You should continue down your path, but basically we're not going to audit you. And the Da Vinci group came up with 2 different possible options for doing peer-to-peer exchange, both based on FHIR, and it's called PDEX. Pair Data Exchange is sort of the implementation guide. And so we have implemented, and I'll talk about that, one version at this point in time of PDEX. This is just a refresher. So what is the data that's been involved in these CMS rules? So it's US CDI core, but the good news is that the rule says version 1, but version 2 just came out. We actually just released US CDI version 2 as part of our 2020 2.1 release. So we are trying to stay current. For the claims information, it was based on what was called CPCDS, Common Pair Consumer Data Set, and again, we have support for that in the product now. We supported the implementation guides for formulary, as well as provider directory, so those FHIR standards. Because by the way, the rule did not say you had to use implementation guides. It suggested strongly that you use the Da Vinci implementation guides. Most of the payers had their vendors use it, or they used it. And again, we supported sort of the access and the security. So this is pair-to-pair exchange. So like I said, it could be any type of transport. It was the US CDI payload from pair 1 to pair 2. But the new version, so there are 2 versions. So I'm going to talk about option 2. So option 2 allows, it's basically a member-mediated exchange. So using the member portal app on your phone, you can use that to authenticate against your old payer and give permission for a new payer to receive that payload. So you're sort of using what we call the framework of patient access APIs, but we're restricting, so we put something in place within the product to say, but you're not sending over claims and formulary, you're just sending the clinical data over. But there are some, sort of aspects of that might be difficult for a member. So for example, you actually have to have credentials with your old payer. And a lot of people, how many people look in their health plan's member portal? Okay, so maybe half of you, which means half of you don't have an account. So if you wanted to move the data, so say you changed health plans. If you want to move the data, first you have to go to your old payer and say, oh, I need you to set me up a member account, and I need to have that on my app. And then, and only then, can I then direct it to new payer, which means I still have to set up an account with new payer. So, but that was sort of the option that was supported because it was using the framework that was already in place, and it was allowing the exchange to happen without sort of investing in new additional overhead in technology from a vendor perspective. So what did we do? To support all of the regs, we did new SDA properties to support data elements needed by PDEX and the implementation guides. We modified the FHIR transformations to generate the PDEX specific profiles. We did this thing called underscore type parameter. That's a search parameter with FHIR, which says, please only bring back clinical data. Don't bring in those other data streams. We did the pair-to-pair. Jonathan talked about this yesterday. Edge gateway, which will allow us to ingest a FHIR payload into SDA, which will be useful for other use cases. And then we plan to support FHIR provenance, and we're working on that now. in the upcoming release, but I know that they're trying to work on a sort of a short-term solution before it comes out in product. And then finally, there's what's called member match, and that's the other way of doing payer-to-payer exchange, which involves new payer doing a query, sending a set of data, demographic data to the old payer, and saying, hey, do you find a match on a member? And then bring the data over, right? The member, you as a member still have to sort of authenticate that and give permission. But at least in this case, you don't have to go create an account with your old payer to bring the data over. But the reason this option was debated amongst the Da Vinci folks is because many risk, compliance, legal departments within payers didn't like the fact that a match might not bring back the right patient or the right member. So there are going to, my guess, because the rule hasn't come out yet, is that it will be an either or. So that both options will probably be suggested in the rule. All right. So 9123P. This was a really interesting set of rulemaking. This came out December of 2020. And the other rule I just talked about, patient access APIs, sort of 9115 was the rule, was for Medicare, Medicaid, CHIP, MCOs, Federal Insurance Exchange. So it sort of had all the federal programs included. Well, in order to skip a 60-day comment period for rulemaking, so whenever a rule comes out, there has to be a comment period for the public to comment. And by taking Medicare Advantage out of the rule, the comment period was only 30 days. Well, why would anyone do that? Because it was at the point in time when the Trump administration was going to be transitioning to the Biden administration. And they wanted the rule to be final before Biden got inaugurated. So they put a 30-day window in. They immediately, I think within 1 week, came back with the final rule. And I think it was like 3 days before Biden got inaugurated. So this rule was actually 9123F for about a week. Biden administration got in and basically said any rulemaking, either preliminary P or F, that has happened within the last 90 days before, we're going to take it back, we're going to do a pause, we're going to look at it. So that's why this is still P, because it got pulled back. And a lot has happened sort of since then. So I don't know what will end up in the new rule, but I can tell you, I'm going to do a really quick flyby of what the differences were between 9115 and 9123 in terms of what they were looking for. So for patient access APIs, big differences was adding into the API was also prior authorization status. So if you had a pending prior authorization, that data should be shared with the patient or the member when they access that data. The other thing is that it was requiring implementation guides, not optional implementation guides, and also referenced the Da Vinci PDEX for prior authorization status, IG. For provider directory APIs, the big difference was, again, requiring the implementation guides. This was a new one, provider access APIs, new single patient. So again, it was the same construct as patient access API, except it was sending that information to the provider, allowing the provider to query and get the data. And so it was clinical, it was claims information minus cost information, pharmacy benefit and prior auth, same set of standards, and again, requiring it. So this was basically, instead of a member querying the health plan, a provider could do a single patient query of the health plan to get information. And then there was another new one. It was the same idea, but it was a provider being able to do a bulk query, so using bulk FHIR. And that was sort of the big new thing, was using bulk, right? So not only was it a provider access, it was also bulk data. And again, the dates are all sort of flown out the window right now. The next one, so if any of you sort of heard me talk yesterday about the work that we're doing around prior authorization, basically DRLS is the equivalent of what was the first two parts of the workflow. So it was the coverage requirements discovery and the documentation templates and rules. So basically this rule is saying you now need to implement prior authorization using the Da Vinci implementation guides. So, and this one is using what was the PAS, the prior authorization support, which is basically sending the actual authorization transaction back and forth. But if you see my note here, in that version of the rule, there was no requirement for providers to support this. So that's kind of like strange, right? Would it make sense if you as a payer had to support this, but you don't have providers that have to sort of stand up the other end of it? But since this rule sort of came and went, there was an RFI from ONC that asked the industry, basically, should we have some requirements, whether it's through their certification program? Because by the way, ONC can only provide guidance and standards around things that sit in the regulations around health IT. They are not programmatic. Only CMS or other agencies that have programmatic oversight can pass rules that say, hey, you health plan have to do this, or hey, you health system have to do this. So if you think about, let's go back to meaningful use, for those of you who remember that program. Basically, ONC had meaningful use, and they had all their criteria, and they had certification, and vendors needed to certify and become, but the actual teeth in that lived in the CMS regs that said if you are, if you want to get paid under Medicare, and you want these incentives that come with being a meaningful user, you need to use these certified technologies. And the and 9115 was the same way, right? So in the CMS part of the rule, it actually referred to all of the technical standards in the ONC side. So you just need to understand, one body does sort of the technical side, and one does the programmatic, and they work together. So the RFI, to go back to this, was from ONC, because the only way they could get this somehow into the certification program is, again, if they created certification criteria as part of a CMS existing program, like an ACO program, or part of promoting interoperability. But CMS has the latitude in this next round of rulemaking to also make it a requirement of a provider. So we'll see what happens there. And again, you saw the slide before, so this is sort of what they're asking payers to do, but again, you really need a provider sitting on the other side of that to make it work. Okay, price transparency. So this one is both payers and providers, and so let's start. I actually want to start with the providers, even though this says payers. So this is interesting. So the rule for hospital price transparency, there are two pieces to it. It basically said you have to have some kind of a file out on your website that's easily found by a patient that shows sort of your charge master, sort of what you charge for various procedures, so that it's easy for them to sort of figure out. Now, if anybody knows what a charge master is, it has absolutely nothing to do with what the payer pays for it or what you pay for out of your pocket. But it exists. The other thing, though, they're required to do is have a tool that basically allows you to do sort of some, querying for different procedures and have a friendly tool to look for, cost for various. And there are certain subset of procedures that you could search for. I went out and actually searched a number of health systems in Massachusetts, and only one of them was it really easy to find that file. When I went to my own health system, it was really hard to find the file. And by the way, if you didn't have an access database, there's no way you would be able to find the procedure that you wanted to find the price for. When I went to try to do the, tool, oh, look at, here's our little tool. Do you know what the tool said to me? It said, go back to your payer and ask them. I was like, oh, well, that's really helpful. So a number of health systems have actually decided that the burden of implementing this was probably far greater than the penalties that CMS would enact upon them. So they just punted. And for the first time, last week, CMS fined 2 hospitals in Georgia. I don't know why they picked those, but they did. But it's not like they just randomly. Apparently they had gone through, this is, in Health IT News or whatever, but apparently they had given them a warning. They had given them a second warning, and they still didn't comply. And one of the fines was, close to $1 million. So I guess the hospital now has to decide, do I continue to just not do it or to get fined? But interesting, because again, it's in the rules, but when you start getting to practical realities, how these get implemented sometimes don't meet what you would expect. So for payers, there are 3 pieces to the version of price transparency. The first one went into effect, and it's very, very similar to sort of what the file looked like, on the provider side. It was like, put up a machine-readable file on your website that sort of shows within your network, contracted providers, sort of the rates that you have agreed to with your contracted provider network. The second phase will be for next year. It will be internet-based self-service tools for members to look for 500 shoppable services. And they've defined it. If you look in the rule, it actually lists 500 services. And what this really means is, again, if I go to the member portal, my health plan member portal, what I should be able to do is say, all right, I need shoulder surgery. Of course, I'll have to figure out what the right code is for that, and I should be able to say, all right, if I had this at provider A, knowing how far into the year I am, which means how much have I satisfied my deductible, and knowing what my coinsurance or copay would be. So this is actually member specific, right? This is not a generic tool because it needs to understand what my accumulator is to be able to give me an answer. How much would it cost me to get that shoulder surgery done at provider A or provider B or provider C based on how you've negotiated with them? That's what you should be able to do. And again, I think there's a lot of sort of work being done, and we're trying to figure out, is there a way that through a combination of sort of UCR, HealthShare, Provider Directory, and IRIS, we might be able to help health plans do this, because we think this is an important thing, and a lot of it is, it's member-centric, which is something we're really good at, right, member data, but it's also this other sort of cost data that comes from a different part of the health plan. And then again, January 2024, same thing, but it's all of the procedures, it's not just 500. So, this just talks about that the machine-readable files, accessible on the website, payment rates negotiated, unique amounts of plan or issue is allowed. So these are just the requirements of what will be required. And then again, I sort of described this, so don't need to go into details. And I think these slides are available generally for folks. So, okay, so almost done here. information blocking. Hopefully many of you are familiar with this, have heard about it. So this was, ONC, basically as part of 21st Century Cures Act, saying that, a healthcare provider, developer, health information exchange, or health information network, that, basically you can't interfere with data exchange. And to a large extent, the provider organizations have really rallied and tried to figure out how to do this. A lot of them have implemented open notes to allow you as a patient access to see those notes without them holding it back, because some practices did have provisions that said, okay, we're going to hold things for a certain number of days, because what if there's something that a provider wants to talk to a patient about? And you can still do that. There are some exceptions to information blocking. So what ONC did is, instead of saying, here is the list of all the things that are considered information blocking, which could have been a really long list, they said, here are the things that aren't. So if you are preventing harm by not sharing information, so say you have a case of domestic violence, and somehow sharing that information might compromise that patient, then that's a legitimate documented reason for not sharing that information in that moment. And again, there's this whole list. It's, promoting privacy and security are reasons. So the privacy piece is consent. So there are certain types of information that still, either under HIPAA or other federal regulations or state regulations, require you to have affirmative patient consent to share it. And if you don't have that affirmative consent, that is a valid reason to not share that information without permission. Same thing, if you think there is a potential for a security problem by sharing that information, like say you have been subject to a breach and you kind of need to clean up the fallout from a breach, you might not want to share anything out of your system until you figure out what happened. Costs incurred, requests that are infeasible, elements on reasonable and non-discriminatory terms, performance, and content and manner. So there are all these reasons. But again, I think that many health systems that we talk to spend a lot of time thinking through this with their CMIOs, with their regulatory and compliance department, with their IT department, to make sure that they understood this. I think, though, that there is this narrow view by some organizations that this is just about patients' access, sharing information with patients. It's not. It is about information sharing with anybody that falls under the umbrella of HIPAA, which means that you can't withhold information from another provider organization if there is a reasonable reason to share that information. Same thing if a payer is asking for information under TPO for their operations, for doing HEDIS measures. You can't withhold and you can't charge money to share that information. And again, one of the things that we think is a benefit of HealthShare is that we do bring in information not just from the EHR. We bring in data because, by the way, today, the data set that sort of falls under under info blocking is USCDI data set, which is sort of this limited data set I showed you previously. But very soon, it's going to be called EHI, Electronic Health Information. That's a big set of data. And it's sort of under HIPAA. And it includes administrative data, some of the operational data. It's a very large data set. And guess what? Do you think an EHR has all of that data? Probably not. So you know that somehow these health systems are now going to have to figure out how do we get all the information in one place so that when we get a request, we can actually share all of the EHI, not just that US CDI data set. I think this is the last reg, and then I'll kind of do what does this mean for you as customers. But again, there was an event notification rule for providers. Again, largely health systems have already implemented this. I think one of the things that we have been working on, and we're trying to find folks to work with us, is if you heard Frank yesterday, Frank Pandolf, talk about Action Engine, is re-engineering and rethinking how we do events overall within the HealthShare platform to make it more, the UI piece, easier to use, to set up those rules, to be able to do attribution, or have a set of rules that say this patient, data needs to go to this provider. And by the way, the payload could be direct, depending on what the profile is. It could be direct, it could be an SMS, it could be, so we're trying to think about how do we more flexibly set up HealthShare. Technically, we can meet this rule. You can configure HealthShare to meet the rule, but I would say it is not as easy as one would like. All right, so the good news is that a lot of the landscape I just covered, we have covered. So we now support FHIR 4, US Core. Like I said, US CDI data elements are all part of sort of SDA. And as of this version of UCR, we are version 2. We have the CPCDS, which are basically explanation benefit plus claim line for medical claims, pharmacy claims, and as soon as it comes out, the dental claims. We've done FHIR mappings into the FHIR US Core for all the CPCDS data set and for PDEX. We've enhanced the SDA to support PDEX profiles, and so it's interesting. So US Core was sort of this set of data elements. PDEX actually had a little bit bigger data set, and so we expanded SDA to make sure we covered all of the data elements that were part of the PDEX profile, which was additional data elements, so that was added. We talked about FHIR peer-to-peer edge gateway, and again, Jim Derrickson, who is responsible product manager for Provider Directory, sort of monitors the work of the Da Vinci PlanNet group and their implementation guide. So, here are the kinds of things that we're trying to help you support. Information blocking, event notification, the No Surprises Act. We're working and thinking about price transparency. And again, if any of you have thoughts or ideas about that, we'd love to talk to you about it. And then pairs, patient access, provider directory, peer-to-peer when it finally lands, but again, we can support it now, no surprises, and again, the payer version of price transparency is something we're looking into. And it's interesting for folks who are part of the Da Vinci project. They were starting to build out implementation guides for some of the price transparency requirements, especially the ones that I was talking about, the good faith estimate from a provider to a patient around a potential upcoming service. So, bottom line, theoretically, these have to be met, right? And we're trying to address that. And so when 9123P becomes the next whatever it is, we'll be spending some time figuring out what it means, what's net new, and how do we build that into the product and the product roadmap so that we can support you. And we're pretty certain that we know PDEX will be in there. We're pretty certain that prior auth will be in there as well. And again, that's something we've already started to kick the tires with our partners, Michael Marchant from UC Davis. So it's in the works. That's all I have. I can take questions.
You mentioned for the options for P2P that there's like 2 options.
Yep.
Do you think it's going to be problematic if like
No, I don't. So the question was, given that there's going to be two options or potentially two options for PDX, will that cause a problem? I think as long as the payload is is USCDI and the transport is fire, sure, it'll be different ways you actually implement it, in different ways you're going to ask your member to interact. But generally speaking, the problem really was making sure there was a standard transport and a set of profiles in fire to support it. That was the real issue payers were trying to hone in on. All right, thanks everyone.